So I work in the Mater Misericordiae University Hospital. So it was a hospital founded by an order of nuns, the Sisters of Mercy, some 200 years ago. I mean, that's all in the distance past now, but the word is often very hard to pronounce for everybody. So my job, I trained in both emergency medicine first and then trained in intensive care. So I do a lot of point of care ultrasound in both specialties. The reason I'm talking on anatomy is about halfway through my training, I stopped doing medicine and taught. I was a lecturer in Trinity College Dublin. It's a very nice university in Dublin. And I taught anatomy for 2 years there, which was great because it helped me to remember all the anatomy that I'd forgotten about from medical school. So I'm sure you're probably feeling the same. You know it really well in medical school for your exams, and then it quickly disappears. So hopefully, will this will try and make anatomy a little bit more relevant to you. Um, it'll be a way for you to sorry, I'm fiddling with the sound, guys. It'll be a way for you to apply the ultrasound images to the anatomy. And I don't know if you guys did actual dissection of cadavers in your medical school or if you just looked at images, but we'll try and apply all of that anatomy to the ultrasound examinations. I'll apologize in advance that my accent can be perhaps a little bit difficult to understand, and I have a tendency to speak very, very quickly. So I will consciously try to not talk too fast. And again, well done for being so enthusiastic to want to learn anatomy on a Friday night. You're all very enthusiastic. Now I can get the slides to work. Okay, there we go. All the kind there's lots of relevant kind of lectures. I do this. I used to. I don't do it anymore. A podcast called Anatomy for Emergency Medicine. There's about 45 lectures on there. They're similar to this type of thing. You can find them all on emergencymedicine.ireland.com. So, one of the biggest challenges when you start using point of care ultrasound and you're trying to wrap your head around what you're looking at, and ultimately what you're trying to explore is a three-dimensional structure with two-dimensional imaging. And you can very easily get confused and you can come to the wrong conclusions if you're looking at a three-dimensional structure in two dimensions. Um, this was a very famous picture when Prince William had his third child, and it was a great illustration of how you need to get images in two orthogonal planes from a radiology perspective. Otherwise, you can make mistakes. What we'd love to see when we do imaging with ultrasound is something that looks like this. We want the detail, we want the depth, we want the color of what we're looking at. But ultimately, what we get most of the time is we either get on the left in medical school and in dissection classes, we get this. It's a very pale imitation of the structure in reality. There's no movement, and we can't see inside the ventricles and the atria without distorting the whole heart. You have to cut it open to get into it. It's hard, very difficult to relate that little kind of pale lump of flesh on the left to the black and white pixels that are moving on the right of the screen. Tools like this one, so this is actually a TOE, a transesophageal echocardiography simulator. Things like this can be quite useful in helping to orientate ourselves to what is going on in the body when we're looking at something with ultrasound. And really, this is the type of thing I'm going to try and achieve with you guys today. I want you to get your thinking in all three dimensions, in all three planes. So we're thinking about coronal and sagittal and axial planes. And we want you to think about how the organs relate to each other. And by relate, I don't mean are they brother and sister or mother and father. I mean the relations are if the liver is here, where is the kidney? Spleen is over here. What's in front of it? What's behind it? All those types of things. Hopefully there won't be too many brand new ideas here. This is designed to be a review of anatomy you hopefully learned or are learning during medical school. What I would love to do is to get you all into a dissection lab with a cadaver like this, and then we could correlate all the anatomy that you have with some surface anatomy on the bodies, and then some ultrasound as well. That would be ideal, but we're a little bit limited to having to use the online teaching model. I think we can get a little bit closer to cadaver lab with CT imaging. So these are all CT scans. They're all showing the same kidney. So keep your eye on that right kidney there, but in three different anatomical planes. So on the left, you have it in the transverse or the axial plane. In the middle, you have the same kidney in the coronal plane. And then finally, on the right-hand side, you have the same kidney in the sagittal plane. Now, here's the front, here's the back, here's the kidney. We're taking slices down this way. Or when we're doing the coronal plane, we're taking slices across this way, and the axial plane, we're taking slices across here. If you can see my comedy movements as I try to chop my head off. Um, these three anatomical planes will come up a lot during the lecture because they have significant impacts on how you're holding, and I'm going to use my phone a lot as our kind of focus probe here. How you hold the probe. If I want to scan my body in a sagittal plane, I'm going to scan it like that. If I want to scan it in a coronal plane, I'm going to scan it like that. If I'm going to scan my neck in a transverse or an axial plane, I'm going to scan it like that. So, for example, here's a common view that you'll get when you're doing point of care ultrasound, the right upper quadrant view. And in this, we'll view the kidney in a roughly coronal plane. That's what we're actually trying to do. We're trying to view this in a coronal plane. And you're holding the probe. Remember, this is the coronal plane, so in a caudal cephalad direction, or the other way around, sorry. Cephalad for head, caudal at the bottom. That's the way the probe is going to be held. And we're going to take a coronal slice through the body. The image we get on the screen will always have the probe at the top, which means you do need to do a little bit of mental gymnastics to get the image the way that you want the image to look like. Because if I'm taking a coronal plane like the mouse pointer across, if I'm doing it like this and I'm doing a coronal slice through the liver, this would be the easiest way to look at it. I'd see liver up here, I'd see kidney down here. But in our ultrasound images, the probe is always at the top and the image is always at the bottom. If we were to think and correlate this with our CT scan, remember we're taking a coronal plane from the right upper quadrant. The first thing we're going to come to is liver, then to kidney, and the same thing over here. You've got liver and you've got kidney. So this ultrasound image in the middle is a correlate of this image here. The difficulty for the ultrasound image to get our heads around is that it's turned 90 degrees up the way because the probe is always at the top. Okay, and that can be a little bit confusing when you're first starting. So we're going to cover the relevant anatomy for the following three kind of point of care ultrasound modalities: the fast scan, the cardiac examination, and a little bit of thoracic ultrasound as well. Let's start talking about the fast scan. So the fast scan is a moderately useful test in the right population of patients. I've heard it described as a useful gateway drug to getting into point of care ultrasound. It's a useful way to learn the basic skills of how to hold a probe, how to get basic images. In clinical practice, I'll tell you a little secret, it's not that useful. Certainly in the original kind of way it was meant to be used, which was for detecting abdominal hemorrhage in trauma patients. Modern trauma care is just entirely dependent on CT scanning. And there is a small cohort of people where the fast scan comes in useful, but for the vast majority, we're going to want CT. But the lovely thing about learning the fast scan is that you can use it for lots of other reasons to find free fluid in the abdomen. So it's definitely a very good place to start. Your question with the fast scan is all about, is there intraperitoneal free fluid? So the peritoneal cavity within the abdominal cavity, you're looking to see, is there fluid in somewhere where it shouldn't be? Normally you shouldn't be able to visualize fluid within the intraperitoneal space. And if you've got a ruptured spleen or a ruptured ectopic pregnancy or any other, or if you've got ascites from liver failure, they will all cause free fluid within the intra-abdominal cavity. In the fast examination, you're not trying to visualize the injury itself. So usually people, from a trauma perspective, if they've ruptured their spleen, blood will then leak into the peritoneal space. But in the fast exam, we're not trying to visualize that ruptured spleen. Now, you can see splenic lacerations and injuries with ultrasound, but the examination is primarily to see the secondary signs, the consequences of the injury. So if we're looking for free fluid with this examination, we need to focus on where we expect to find free fluid. So let's go back to our right upper quadrant view that we had a few seconds ago. So this is the patient's right-hand side, and we're scanning a coronal plane. The head of the patient is up this end. The feet of the patient is at the left-hand side. And what we're imaging here is we're seeing a little bit of liver. We're seeing spine at the back. We're seeing the kidney in the middle. And we're looking for this space here primarily, a thing called Morrison's pouch. Now you'll see there's a bright white line runs across here between the liver and the kidney. This is one of those potential spaces in anatomy, in that normally it's just the two surfaces are opposed to each other. There's no space between them. But as fluid leaks into the peritoneal space, that will separate out and you'll see a black line between the kidney and the liver. And I'll show you some examples of that. Just to go through that again. So how do we relate this to our CT scan? Here we have imagine our probe is taking an ultrasound. We've got the head up here. We've got the feet up here. We're on the patient's right-hand side, and we're taking a coronal slice. Remember, the coronal slice was this way through the body, and we're going to see liver. We're going to see a bit of kidney, and we're looking for this Morrison's pouch in between. The difficulty, remember, with ultrasound, though, is the image looks a little bit more like this on the ultrasound because the probe is always at the top when you're taking ultrasound images. So here I just want you to be able to correlate what we're seeing on the CT scan. A little bit of liver, a little bit of kidney, a little bit of liver, little bit of kidney, and Morrison's pouch is that little space in between. Let's look at an example of free fluid. Let's say this man has been in a car accident and he's broken some ribs on the lower right-hand side of his thorax and his blood pressure is low. So you'd be worried about bleeding into the abdomen in that scenario. So you place the probe in the right upper quadrant in that kind of probe marker at the top, and then the other marker pointing down, and we're scanning in this coronal plane. Remember, we're slicing across that way. And you'll end up with a coronal slice that looks a little bit like this. We'll start off with the CT scan again. We've got our probe, we've got a few ribs at the side, we've got a bit of liver, kidney, and our Morrison's pouch in between. If we look at it, what it looks like on ultrasound, you're going to get liver around here, you're going to get kidney there, and here we're seeing a black stripe of fluid. And that black stripe of fluid in this scenario is going to be blood. But again, remember, when you get the ultrasound, it's going to be this way around. Just to make your life more difficult, it'll be upside down. So remember that the fast scan is all about trying to find free fluid in the peritoneal cavity, and I've highlighted the peritoneal cavity here in blue. So the peritoneum runs over the top of all the organs. It kind of folds back on itself. It forms this continuous potential space. Blood from the liver can leak from all the way around the liver down into the pelvis through the peritoneal space, and fluid can move wherever it wants there. But in the patient lying on their back, and remember, we're examining almost all of these patients lying supine in the trolley, especially after trauma. Let's say they have 100 or 200 milliliters of blood within their abdomen. It's going to end up in Morrison's pouch, that bit between the liver and the kidney, because it's gravitationally, it's the lowest part of the abdomen. They call it the most dependent part, the lowest portion when you're lying on the back. And because gravity will draw fluid down towards the lowest point, that's why you'll find fluid in Morrison's pouch first. So for all the views you do of the fast scan, we've got the right upper quadrant, left upper quadrant, the pelvis. The right upper quadrant is probably the most sensitive one because that's where fluid is going to accumulate first, at this lowest point within the abdomen. Once you get enough fluid, so especially in things like ascites related to liver failure, and your ultrasound isn't going to be able really to distinguish whether the fluid in the peritoneal cavity is blood, or whether it's ascites, whether it's acute, or whether it's chronic. But if you get lots and lots of free fluid within the abdomen, then all the organs can get almost completely surrounded in fluid. But it will always go to Morrison's pouch first because it's the most dependent area. The one place that you won't see fluid is a place called the bare area across the liver. So the little white bit there marked out, that's peritoneum folding back on itself. And you see it folds back there and it folds back there. But you have an area of the liver called the bare area. So fluid can't get into this area. It's just the liver against the diaphragm. And so you have this little patch where you're not going to see fluid. So let's look at this CT scan here. Okay, so this is a coronal CT scan. Okay, so we're slicing across this way. I'll bring you back to the start of the clip. So we're at the very front here. You can see all the ribs and the sternum there. And then as we come a little bit further back, we're starting to see the heart. And then we're seeing the diaphragm and the liver coming in, going in there. Okay. And then as we go further and further back, we start to see lots of intestine. We see the pancreas just in there. And if you keep your eyes on this structure there, that's the gallbladder. Okay, I'm going to keep moving backwards. As we keep moving backwards, you're going to see something that looks like the kidney popping in just there. Now again, in the coronal plane, this is where Morrison's pouch, this is where we're going to see our fluid. But remember I talked about the relations, what structures are nearby to Morrison's pouch, and what fluid-filled structures near Morrison's pouch might we confuse for free fluid in the abdomen. And if I move back forwards, it's going to be the gallbladder. If you get a chance when you're doing your hands-on stations, you'll see the gallbladder, and lots of people, the gallbladder has black stuff within it, that's fluid. It's contained within the gallbladder, but sometimes people, when they first start ultrasound, because the gallbladder lies relatively close to Morrison's pouch, they can sometimes say, oh, look, there's free fluid in Morrison's pouch, and it's actually just the gallbladder. Other place to look for is the very inferior tip of the liver. So if I move back anteriorly again, the kidney's not visible now, but you will get blood collecting around this area here. And so it's important when you're doing your ultrasound just to check that very caudal part, the most bit nearest the patient's feet of the liver that you can see, because you'll often see some fluid in there as well. Okay, left upper quadrant view is similar to the right upper quadrant view. Again, the probe marker is orientated up the way as we're taking a coronal slice. The only difference is we're doing it on the left-hand side of the body. We should see an image that looks something like this. The thing that I think is really crucial on the left upper quadrant, which is different from the right upper quadrant, is that you have to see the diaphragm. Can you see the diaphragm there? This bright white structure that's kind of moving a bit. There's a little bit of an eye of faith needed here, but this is the diaphragm. The reason being that the first place that fluid will accumulate in the left upper quadrant is not between the spleen and the kidney, which is down here. So this is the kind of left upper quadrant equivalent of Morrison's pouch, the spleno-renal angle. The first place for fluid to accumulate is actually above the spleen, between diaphragm and spleen in there. So if you don't visualize the diaphragm on the left-hand side, you may well be missing some free fluid in there. Just to mark on the spleen and the kidney again. So in this dissection video, you can see this guy get his fingers well down in between the diaphragm and the spleen. See how far he has to reach back there? There's the spleen in front of his fingers. That little gap where his fingers is, that's where free fluid is going to accumulate in someone who's got intraperitoneal bleeding. And that's the space that you're trying to visualize when you're doing your ultrasound. So for left upper quadrant view, what we find is you have to have the probe quite posterior. Some people talk about knuckles to the bed. As you're holding the probe, it has to be way down in the back with your knuckles touching onto the bed. And again, we're slicing in that same coronal plane as we did for the right upper quadrant view. You could see a corresponding CT slice. So I've kind of turned everything here to try and make it hopefully a little bit more logical for you. This is the patient's left side. You can see a couple of left-sided ribs. This is the spleen just here. You can see a little bit of kidney that we have there. And where the fluid's going to accumulate is just in there. Now, the spleen is much smaller than the liver, and that means you get a much worse acoustic window. So the liver is huge, takes up the whole kind of right upper quadrant, and it's very good at transmitting ultrasound waves, and so it's very easy to visualize through the liver. On the left-hand side, the spleen's much smaller, so you need to get your probe over the spleen, so you're using that as your acoustic window. Then on ultrasound, we get an image that looks something like this, where we have spleen and kidney, but ideally what we're looking to see is a little bit higher. You'll want to move your probe a little bit further towards the patient's head, because you're trying to see the diaphragm, and you're trying to see that space between spleen and diaphragm. So putting this all together, again, here's another example, a sample of free fluid here. This curve that you see here with my mouse pointer, that's the diaphragm. This structure here is the spleen, and all the black stuff above it is free fluid within the abdomen. Again, let's look at our little, coronal CT scan, if I can make it work. There we go. So we're starting at the front, moving back. This time look at the left upper quadrant, and you'll see that I have to go much further back this time in scanning through before I see spleen and kidney. Whereas here the liver is almost completely gone. Now I'm just starting to visualize the spleen. Where we're looking to see is the fluid between spleen and diaphragm, and sometimes you'll see it between spleen and kidney. The main fluid-filled structure that lies nearby, if I come back towards the patient's front again, the main fluid-filled structure is going to be this thing here. Now, this patient didn't have a very full one. This is the stomach. Now, you might see this doing your hands-on sessions tomorrow, especially after lunch and after coffee, because your models will have full stomachs, and you may well see fluid-containing structures in the left upper quadrant, but just be sure to tease them out that they're different from free fluid. It's fluid within the stomach. It's an important nearby relation that could be confused for free fluid within the abdomen. Okay, we'll move on to the pelvis part. Now, the pelvis part of the FAST examination gets tricky for a few reasons. Firstly, you need to get views in two different planes. Secondly, in terms of when I say planes, I mean you're getting a view in a transverse plane, and you're getting a view, so a transverse plane is this one, and you're getting a view in a sagittal plane as well. The second reason it's difficult is that the anatomy in the pelvis is different for the male versus the female. So the fluid will accumulate in slightly different spots. So if we look at this here, this is our transverse view. Probes at the front over the bladder. We're scanning through the bladder and looking at the organs behind. So we've got lots of black fluid within the bladder here. This will be the rectum down here, and you can actually see a little bit of the pelvic side wall coming in as they fan through it as well. In the sagittal view, the probe is put in this position, with the head at, in this view, what are we looking at? Yeah, heads at the left-hand side and feet at the right-hand side. And here we're looking through the bladder again, and we're looking to see is there fluid out the back of the bladder, and then we're fanning from side to side as well. So in the female, in the dependent position, in other words, lying flat, when I say dependent position, I mean where will the fluid accumulate in related to the position of the patient. Fluid's going to lie at the back, most commonly between the uterus and the rectum, something called the pouch of Douglas, which you'll have heard of. So this is the first place you're going to find fluid, because the rectum at this stage in the sigmoid colon is retroperitoneal. It's not an intraperitoneal structure. So the fluid, if you've got free fluid in the abdomen, is going to collect behind the uterus and in front of where the rectum is, in this place called the pouch of Douglas. Now, if you have lots of fluid, it'll spill over and you'll see it between uterus and bladder as well. But the first place you're going to see it is between the uterus and the rectum at the back of the pouch of Douglas. And when it comes to men, you've just got the bladder and the rectum. Remember, the rectum is retroperitoneal, so you're going to see fluid collecting in the retrovesical pouch, so just immediately posterior to the bladder. Again, this is just to review again. This is kind of a three-dimensional oblique view. We're looking at the female on the left-hand side here. The peritoneum, you can see it kind of turning back on itself here and here, and it turns back on itself there to cover over the sigmoid colon and the rectum. Remember, when the patient's lying flat, this will be the most lowest part of the peritoneal cavity, and you're going to find fluid going in there first. In the male, we're looking in the retrovesical pouch just there. Can you see the way this peritoneum turns back quite early? Now, I've marked a little area in blue, this area. This is not within the peritoneal cavity, and you should not see free fluid in this area. And why that's important is if you angle too deeply into the pelvis, if you angle appropriately when you're doing your fast examination, you're going just above the symphysis pubis, you're scanning through the bladder, and you're catching free fluid in the retrovesical area. So this is bladder, this is free fluid. If you're angled too deep into the pelvis, like I've marked in the red line there, remember this area is not within the peritoneal cavity. What does lie there are the seminal vesicles, if you remember those from medical school. This is in the male. And they can look really quite like free fluid. So that can be a common false positive when people are angled too deep. And by angled too deep, they're in the transverse plane and they've tilted the tail all the way up. They're kind of shooting down too far into the bladder in the male. You can sometimes see something that looks like free fluid, but is actually the seminal vesicles. So in the male pelvis, because of that, you'll typically see fluid off to the sides. So this is our transverse view. And you can see the way there's no fluid immediately behind the bladder because they're taking an appropriate transverse plane. But you can see some free fluid just off to the side of the bladder there. Can you see that? And then in the sagittal plane, so the probe is turned from being in this plane to being in this plane. You can see the fluid. This is this retrovesical or rectovesical pouch just here. This is the area I'm talking about with the seminal vesicles, and you can just sometimes, you can cast them just in there as well. In the female pelvis, things can look a little bit different. When there's lots of fluid, you can see the uterus suspended. So this is the uterus, and this is going to be suspended on its ligaments, with bladder at the front with lots of free fluid behind. This is in the transverse plane. Remember, we're scanning in this plane at the minute. Things will look quite different when you're looking in the sagittal plane. This has been cleverly dubbed, I think, the TIE fighter sign. Again, I can see this, everybody else does. Can you see the body of it there? The wings of the TIE fighter. So in this transverse plane in the female pelvis, when you've got lots of free fluid in the pouch of Douglas, you can get something called the TIE fighter sign. Okay, let's move on to talking about the cardiac views. Now, the cardiac views are difficult. A lot of the reason I think it's difficult is that none of the planes are standard. So far, we've been talking about transverse planes, sagittal planes, and coronal planes. You can't really use those when it comes to the cardiac views because the heart itself doesn't lie in a simple up-down plane. It lies in a very twisted fashion within the thorax. Remember, it doesn't lie right in the midline, it's just left of the midline. The right ventricle isn't really the right ventricle, it would be better described as the anterior ventricle. The whole thing is twisted round. And because nothing is kind of standardized, the whole thing is very asymmetric. And so the views that we take are determined by the available sonographic windows. So we take the views where we can visualize the heart away from the ribs, away from the sternum, for example. So you're really up against a big challenge trying to orientate yourself. So my nifty little trick of showing you CT scans and things is not going to work for the heart because it's just really very awkward structure to do. These were some of the more helpful images that I found online. This is actually a plasticized pig heart. So they've taken an anatomical specimen and they've cut it and sliced it to represent the views that you get when you're doing cardiac ultrasound. The added difficulty that you get with cardiac ultrasound is the whole thing moves really quickly. The kidneys have enough sense to sit still, which makes it a lot easier to image them, but the heart is continuously moving with each beat, and that can make it quite challenging to visualize. It also makes it much more interesting to look at, and I'll confess, the heart is my favorite organ. Definitely echocardiography is my favorite one by far. Okay, so the subcostal view is often one of the first cardiac views that you'll learn as it comes with the fast examination. So we do the right upper quadrant, the left upper quadrant, the pelvis, and you typically finish with the subcostal view. Now, subcostal is going to be with the probe in a kind of a, again, the coronal transverse thing kind of goes out the window when it comes to it, but you're going to place the probe just under in your subxiphoid space. The tricky thing about this one is the orientation. Remember, the probe in ultrasound is always at the top, but actually this is the bottom of the patient and this is the head of the patient. Okay, so the bottom of the screen is the top of the patient and the top of the screen is the bottom of the patient. This is only the beginning of how things get tricky with cardiac ultrasound. However, I think the view is relatively easy to understand because we can see the main chambers and valves of the heart all in one view. So it's relatively intuitive. We can see, I'll show you it here, left ventricle, right atrium, and left atrium just here. The other important relations on this is that we're scanning through the liver. We're using the liver as our sonographic window for ultrasound waves to get through. And remember, liver's in the abdomen and the heart is within the thorax. So this bright white line separating them is going to be the diaphragm and then the pericardium resting against it. There's an apical view that we take, so that will be taken where your apex beat is, if you remember that from clinical examination. Again, I think this view is also relatively intuitive to get your head around because again, you're seeing all four of the major chambers plus the two atrioventricular valves all within the one view. So here we have left ventricle, right atrium, left atrium. The parasternal long axis view is one of the views that people find hardest to orientate anatomically. So the imaging plane for the, again, I'll show you, I'll stand up, I'll tilt the camera a little bit. Imaging plane for the parasternal long is you're pointing the tip of the probe towards the right shoulder, okay? You're slicing, if my heart is like my hand running down here with the atria at the top and the ventricles at the bottom, I'm taking a long slice through it when I place the probe. So we'll run through the chambers on this one first. So again, we have, left ventricle, left atrium. We've got descending aorta, we've got ascending aorta, we've got the right ventricle, and you can see the wall of the right ventricle there as well. So there's lots that you can see in this view. And remember the flow of the blood here. What you can see is blood enters in the pulmonary veins, which aren't on the screen. Blood drains from the pulmonary veins into the left atrium. Blood moves from left atrium through the mitral valve into the left ventricle, and then it's pumped out through the left ventricle, through the aortic valve into the ascending aorta. So the flow of blood is left atrium, left ventricle, and then out through the aorta. The parasternal short axis view involves rotating 90 degrees to the starting position. Let's go through this. So I'll put my camera down again. So if my heart was running this way and I was running in a long axis along the length of the heart, when I go to the parasternal short axis view, I tilt the probe 90 degrees. So now the probe marker is pointing towards my right shoulder. So parasternal long axis, which is the view that's on the screen at the minute. parasternal short axis is this one. So you're just flipping 90 degrees on the view, and you're flipping 90 degrees along the dotted line. So everything that you see in this white dotted line here, along here, and along here, you're going to see all of these structures on the parasternal short because this is what you're rotating about. So when you go to the parasternal short axis, you're going to see bits of the right ventricle, you're going to see bits of the anterior septal wall, you're going to see the two mitral valve leaflets, and you're going to see the posterior wall. And if we turn, as I say, onto 90 degrees, that's what we're going to see. All of those structures, everything that's along this white dotted line, we're now seeing in here. We've got right ventricle, bit of the anterior septal wall, we've got anterior and posterior mitral valve leaflets, and then we've got the inferior wall down there. Turn the camera back up again. Looking at this again, so we're using our I'm just going to take a drink of water. Using our plasticized pig model. On the right-hand side, we have the parasternal long axis views, RV, aorta, left atrium, left ventricle. And again, this is our plasticized pig. We've got left ventricle, mitral valve, left atrium, aorta going through there, and right ventricle up here. When you're doing a parasternal short axis, you're taking a slice right down here, down this dotted line, just as they've done this pig heart. And then they remove this bit, and they're showing you looking down into that. And when you look down into this, this is what you see in the short axis. So you see what I mean by slices. You're slicing the heart in different planes. In the long axis, you're slicing along this. In the short axis, you're slicing the heart at 90 degrees to the axis of the heart. And you'll either take one at the top end of the aortic valve, one at the mitral valve, like it's on the screen at the minute, one at the papillary muscles. You'll do all this in your workshops. So we're taking different slices through the heart. Arterial supply to the heart is important as heart attacks and obstruction of the coronaries are important. And if the blood stops to any given section of myocardium, then the myocardium will struggle to contract. So normally the myocardium works really well, but if one wall of the heart stops getting blood supply, what you're going to have is one wall moves and the other one doesn't move. So this is something that you can actually identify fairly easily on echocardiography. You can, of course, see it on electrocardiography, on ECG, and the patterns that you see in ECGs will tell you which coronary artery is affected. So it can be really nice to correlate the echocardiographic findings with what you see on the ECG as well. So when you first step is hopefully, and again, as a clinical skill, it's really important you do the ECG before you do the echo, because the ECG is usually the thing that will determine what's going to happen to them next. Do they need to go and have an angiogram and a stent put in the coronary artery? But if you need a little bit of help identifying is the heart suffering from coronary ischemia, echocardiography can be really useful. Now, I think learning this is far too advanced for the stage that you're at. I really just want you to be aware that you can identify this on cardiac ultrasound. Okay, I'm going to talk a little bit about the major valves. The mitral valve is fairly easily imaged with echo, and it consists of two leaflets. So the mitral valve is the valve between the left atrium and the left ventricle, and you've got two leaflets here, nicely named the anterior mitral valve leaflet, which conveniently happens to be the most superior one, and then the tiny little posterior leaflet below it, and this is the correlate on the other image. Pardon me. The mitral valve opens during diastole when blood moves from the left atrium to the left ventricle. Because remember, your left ventricle will contract, empty 60% of the blood within it. That's its stroke or its ejection fraction. So 60% of the blood is ejected. The left ventricle will then relax, and there's kind of a suction effect, and it sucks blood from the left atrium into the left ventricle. The mitral valve will have to open to allow that blood to move from left atrium into left ventricle. When the left ventricle then contracts again, that mitral valve, and it's really cleverly designed, it's got like a little parachute, it's got the chordae tendineae that stop it from turning inside out. The mitral valve will snap shut, and it's not just like a triangle, it actually has little bits that come flat like that, and you end up with the mitral valve closing like that. And it provides a solid barrier so that blood continues to flow out of the aorta instead of back into the atrium. As it looks on ultrasound, the anterior mitral valve leaflet is bigger than the posterior mitral valve leaflet. And these important things are the chordae tendineae that stop the valve turning inside out during cardiac systole. The aortic valve is also fairly easily visualized. It has three leaflets, and you can see them here. Hopefully you can see them on this. You can see 1, 2, and 3. 1, 2, and 3. It's different in structure from the atrioventricular valves, the mitral valve and the tricuspid valve. It doesn't need any of those chordae tendineae, those little heartstrings. It's probably worth knowing what the different cusps are. So this is again, this is a parasternal short axis view. I'll show you again. Remember, heart is running this way. This is one of my parasternal short axis view. Instead of looking at the mitral valve, I'm this time just tilted a little bit further up so I can see the aortic valve. You have the right coronary cusp, which is nicely beside all of the right ventricular structures. You have the left coronary cusp, and you have the non-coronary cusp. Okay. The reason they're called right coronary cusp and left coronary cusp is, at least see this a little bit here. This is the left coronary or left main coronary artery, and you can actually see it just there. See that little black line on the echo there? That's the left main coronary artery, and it comes off at the base of the left coronary cusp, and the right main coronary artery comes off at the base of the right coronary cusp. And the non-coronary cusp is all alone and does not have a coronary artery associated with it. The non-coronary cusp is easy to identify because of the intraatrial septum. Left atrium, right atrium, septum in between. The cusp that we see this cusp here? This one there, beside the intraatrial septum, that's the non-coronary cusp. In terms of what pathologies you might see in an aortic valve, one of the commonest things you'll see, especially in older patients, is calcification. As patients age, they develop calcification of the valve, and here you can see it. There's see this white, it looks like a little lumpy rock sitting on the right coronary cusp. And you can actually see, we know it's calcification because if you look behind it, and this is an important thing for ultrasound in general, there's a shadowing artifact behind. The ultrasound waves are hitting this, but they're unable to pass through it, just like bone. And so what you can see is behind it, in this, you can see some shadowing as the valve moves along it. Okay, I can see the time now. We're at 8 o'clock. I have another 10 minutes I can do, which I'm going to plow on with. If you want me to stop, or if you're really under pressure, just turn on your mic and tell me to stop talking. But I should be done in the next 5-10 minutes if that's of any use. So we'll talk a little bit about some thoracic structures, which is relatively straightforward. We don't do a huge amount of thoracic ultrasound. Let's give an example. Let's say you're dealing with someone with left-sided pleuritic chest pain. And so by pleuritic chest pain, I mean pain when you breathe in. And it's on the left-hand side. When you listen with your stethoscope, there's reduced air entry on that left-hand side. So what are we looking at here, and what's the anatomy involved? And I put up 2 images here, ultrasound. This is his right side, which was the normal side, and his left side, which is the abnormal side. We'll come back to that. What we're looking for on this scan is we're looking for a pneumothorax. And so that's when the lung is collapsed. And what we're looking for is something called pleural sliding. So I want you to look at this bright white line here. See, can you see there's a shimmering effect? I've heard this described as little ants marching up and down the line. It's another description. That is pleural sliding. And that's the 2 layers of pleura sliding over each other, as normally happens when you breathe. And the 2 layers of the pleura are the parietal pleura, which is adherent to the ribs, and the visceral pleura, which is adherent to the lung itself. And in a normally inflated lung, and you and I and everybody else, the parietal and the visceral pleura are in contact and they slide over each other. And the effect that we see on ultrasound is this shimmering line that we see there. And how I know that that's the pleural line is that it is deep to the ribs. Can you see a rib here and a rib here? The view for this, again, I'll show you, is we're in a sagittal plane here. So I'm going to move my phone as my ultrasound probe here. And we're in an up-down plane, and I've got the probe resting on 2 of my ribs. And the pleural line lies just in between. So rib at the top, rib at the feet end, and the pleural line is the one that's deep to it. Really important to find the ribs, because that way you can identify which one is the pleural line. Otherwise, there's just a bunch of bright white lines. The pleura and the thoracic cavity goes from like a low point all the way here at your xiphisternum. So you take your fingers and put it on your xiphisternum. But the thoracic cavity extends way, way, way deeper down. So it'll go down another 3 or 4 rib spaces over towards near where your kidneys are. And again, it comes all the way up high to just up here at the apices above your collarbones. And that's the pleural cavity. So what we're seeing in that original ultrasound, remember our patient had, we'll say this is the left-hand side, this is the right-hand side. We had loss of pleural sliding because the 2 layers of pleura are no longer in contact. Instead of the visceral and parietal pleura sliding over each other, they have become separated. And what we see is a loss of pleural sliding. So you can see that the bright white line here moves with respiration, but there isn't that shimmering effect that we can see on the normal side. Again, spend some time looking at this in your workshop. It's a really important thing to see. And the anatomical correlate is marked here. So the visceral pleura in the red line and the parietal pleura in the yellow line. We have a large pneumothorax here. And this is the ultrasound would look like in this patient. And that's a CT, what it would look like. To give you another view of it, this is a thoracoscopic view. So it's a bit like laparoscopy. You can put cameras and little tools in through little holes in the chest to have a look at the inside of the thoracic cavity. This area over here, this is parietal pleura. This is, oh, wait till that drops out of the way. This is parietal pleura. You can see ribs and all there. Visceral pleura will be covering this lung here. And in a pneumothorax, where the lung has collapsed down like this, you've got loss of pleural sliding because these two layers have lost contact with each other. Another common use for thoracic ultrasound is to look for fluid. So here we have a lovely image of the left thorax here, and we've got a large pleural effusion. The pleural effusion is this large black area there. Remember, on ultrasound, fluid appears black. But again, how do we get this view? So we are back in the coronal plane again. Remember, this is the coronal plane. And we've orientated ourselves a little bit like this. So let's turn it around this way, because that's more like what the ultrasound is, and the probe is just on there. So this is the patient's left side of the chest. Here's our spleen, here's our kidney, what we were looking at earlier. So we're really just a few rib spaces up towards the head from where we were earlier on. And what we're visualizing instead of lung tissue, because you can't really visualize lung tissue very well with ultrasound, it just looks fuzzy. But because there's lots of fluid there, and ultrasound loves to pass through fluid, we can see this large pleural effusion. And this little wriggly thing up here is collapsed atelectatic lung. So because there's so much fluid in this pleural cavity, the lung has become squished down, and you can start to see the lung floating about in the pleural fluid. Once we've found something like a pleural effusion like this, ultrasound can be really useful to help us put a drain in it, or to aspirate some of the fluid, put a needle in it, and ultimately put a little plastic tube in so that we can drain the fluid out. But one of the difficult things about putting needles, particularly in the chest, is we worry about hitting blood vessels on the way in and causing bleeding. Now, when you learned in medical school, you learned that the neurovascular bundle, so the vein, the artery, and the nerve, were all tucked in nicely underneath this little notch in the rib, that neurovascular bundle. So theoretically, if you put a needle anywhere in here or a knife in here, you're not going to cut through an artery. However, patients don't seem to read our textbooks, and the blood vessels seem to run wherever they want. So these are lovely little anatomical studies just to illustrate that patients do not follow real life. So here's CT angiography. So there's contrast in the arteries. The bright white bits are ribs. This is the upper border of the rib. This is the lower border of the rib. And the squiggly things running in between that space are the intercostal arteries. Now, again, if they followed the textbook, we shouldn't even be able to see those. They should be tucked underneath the rib. Again, another anatomical study correlated here that this is rib, this is rib. This between the two yellow pins is the space in between, and here you can see multiple blood vessels, the red artery there and the vein down below. So because of that, you always run the risk of sticking your needle or your dilator or your scalpel through a relatively squirty blood vessel when you're doing a chest drainage procedure. But again, ultrasound can help here, and we can use something called color Doppler, which is a way of assessing flow within blood vessels. Not necessarily to visualize the proper round blood vessel itself, but to visualize, can we see flow? And that way we can avoid putting a needle in anything. So this is our typical pleural ultrasound view: rib, rib, pleural line, again rib, rib, and this is pleural line. And the arteries is certainly located close to the lower border of this rib. So if I was to put my needle in here, if there's a fluid collection, I'd want to make sure my needle was coming in just in here. Okay, so we've looked through the fast scan, the four views: right upper quadrant, left upper quadrant, the two views of the pelvis, sagittal and transverse. We've looked at the cardiac views with the subcostal, the parasternal short. Again, I'll show you this. The parasternal long, the parasternal short, and then the apical views, which are way down at the apex beat. And then we've done a little bit of thoracic ultrasound looking at the pleural cavity and the fluid collections that might be there. Okay, so I'm sorry I'm not with you there to help you through your scanning, but I hope you have a good time at the course, and I hope you learn loads. And that's me all done. Thanks, Mel. Thank you.
It's already gone. Okay. Thank you very much, Andy, for your presentation. Also, erstmal da. Yeah, thank you very much. It was beautifully animated. I would never even dare to video call you without having prepared anything similar. So thank you very much. Um, does anybody have a question from the audience or from our online audience? Okay. Then I will have two questions.
Sure.
First of all, yeah? Okay. First of all, I've been stalking your website for more or less short time. I found out that you've been teaching in New Zealand as well. So can you tell us about how has the use of ultrasound changed in over the past years in Ireland and in New Zealand? Probably, yeah, since you've started your career.
So I graduated from medical school in 2004 and I took up my consultant or my specialist post last year. So it took me 18 years to train. So I was a very slow learner from leaving medical school until getting my kind of final specialist training. When I started, I did my first kind of central line, for example, so a central venous catheter. I did that in 2005 and ultrasound was not an option. So we learned everything based on landmark technique, just you angled the needle in the right way. Then from about, I would say, 2010 onwards, it became everywhere had ultrasound for doing central lines. The second big change I saw was probably echocardiography, so being able to look at the heart. Being able to look at the heart when I was started looking after really sick patients in the emergency department or the intensive care unit, I would have loved to have done it, and it was almost like magic when somebody came along and like a cardiologist would come along and look at the heart. But over the past 10 years, it's become clear that anybody who looks after sick patients should have skills in being able to do cardiac ultrasound because it so quickly differentiates your type of shock. So if we think about shock as distributive shock, cardiogenic shock, obstructive shock, diagnosing pericardial tamponade, you can within seconds narrow it down into which box, which category of shock you're dealing with, and that massively changes what you do with the patient. And now, it's certainly in Ireland, I think there's 3 or 4 ultrasound machines in our intensive care unit. There's 3 or 4 in the emergency department. There's none on the wards for some reason. So only the ICU and the ED has all of the point of care ultrasound machines. But it's been a huge change over the past 10, 20 years, definitely. I couldn't really work without it these days.
All right, so it has become even more popular
Yeah.
around the world. Yeah, second question. Do you have any view or any skill regarding ultrasound that is most advanced and most important for you?
So do you mean the most difficult ones?
Yeah, the most difficult ones.
So and when I was doing my intensive care fellowship, I spent 2 years doing cardiology training in echocardiography. So again, in Europe, you guys may have aware of the European Association of Cardiovascular Imaging, so the European Society of Cardiology. They have an accreditation process for echocardiography that involved doing like 300 scans and all full kind of cardiology level scans. Um, you learn all the fancy Doppler stuff. You learn to measure cardiac output. You learn all of the really kind of high level echo stuff. But I'll tell you a secret is that you get 95% out of value from doing the simple 4 views by doing parasternal long, parasternal short, apical, and subcostal. Just using the 2D, you don't even need to use color. You'll get 95% of the value of echocardiography by doing the simple views. So while I've done all the fancy stuff, I actually don't find I use it that often. So I think it's really key you learn that. The other thing is procedural stuff is to get really good at getting a needle into a vessel. And this can come, obviously you do it when you're doing central lines, but you can also do it doing peripheral cannula when you're doing pleural effusions. So being able to track I'll get a pen. Being able to track the tip of a needle with an ultrasound probe. So typically when you're doing an ultrasound guided cannulation, you have your needle coming in here and you have your probe here. You need to be able to track the tip of that needle all the way down into the blood vessel. And that usually means tracking the tip of the needle like this, moving your probe every time you move the needle. Otherwise, you're just tracking the shaft of the needle and not the tip. So I'd say that's the other skill to get really, really good at, is being able to get a needle into a vessel and track the tip the whole way. And peripheral cannulas, so the simple IV lines that we put in the arm, if you can put those in really, really well with ultrasound, central lines will be easy. So central venous catheters, while it's a much bigger thing and it's near important structures, it will be easy if you can track the needle tip.
Okay, thank you very much. That sounds good because we have a workshop tomorrow where all of you can track the needles. Yeah, thank you very much.
There is one more question.
Yeah.
One question from Andy, who's online with us. His question is, why do we see pleura behind the ribs?
Can you repeat? Sorry, you're just breaking up a little bit there. Could you repeat the question?
Yeah, why can you see pleura behind the ribs?
Can you see bulla? Is that correct?
Pleura. So the
Pleura. Oh, pleura behind the ribs. Yeah. So sometimes I didn't mention this in the presentation. So on that image I had of the two ribs with the pleura underneath, you could see pleura all the way underneath the ribs. You should not normally be able to see that because ribs will reflect all ultrasound. The reason you could see it in that view is that my probe was here rather than here. And as you move from lateral to medial, the ribs go from being bony to being cartilaginous. And that was a view of the cartilage, the costal cartilages. And that does transmit ultrasound. And that's why you could see the pleura behind the ribs there. Do it in the workshops tomorrow. Put the probe on the ribs and then move from way out laterally to way medially, just as close to the sternum. And you'll see that you'll be able to see the pleural line underneath the ribs.
Okay, thanks. That makes sense.